Apologies to everyone, go.
Hello and welcome to today's WHO press conference following the WHO consultation on the composition of the influenza virus vaccines for use in the 2025-26 Northern Hemisphere influenza season. WHO was hosting the consultations for the Northern Hemisphere influenza season from 24 to 27 February this year at the Crick Institute in London, the WHO Collaborating Centre. Now, which is also why we have this bit difficult setup right now. We're here talking from Geneva to you, and I'll introduce the panelists in a moment, but most of the panelists are actually sitting at the Crick Institute in London following this consultation meeting. There was an information meeting this morning, but now we're having the press conference. Very happy to be with you, and apologies for the slight delay. Now let me introduce the participants. Here with me in the room is Dr. Mike Ryan, Executive Director of WHO's Health Emergency Program. And over at the Crick Institute in London, we have Dr. Maria van Kerkhove. She's Director ad interim for the Department of Epidemic and Pandemic Threat Management at WHO. We have Dr. Wenjing Zhang. She's Head of the Global Influenza Program at WHO. Then, of course, very happy to welcome Professor Ian Barr, Deputy Director at the Victorian Infectious Diseases Reference Laboratory. And last but not least, Dr. Richard Webby, Director at St. Jude Children's Research Hospital. Thank you all very much for joining us today, ladies and gentlemen, and very happy to do this today. Now, for journalists online, the usual practice, please make sure that you're properly identified, because if you're not properly identified, we cannot give any questions to you. And if you want to take a question, then please raise your hand with the raise your hand icon, and we'll take it from there. With this, enough from me, and I'll hand over to Dr. Maria van Kerkhove for the opening remarks.
Thank you, Christian. Good morning, good afternoon, good evening. Before sharing information about the results from the WHO meeting held this week about the composition of the influenza virus vaccine for use in the 2025-2026 Northern Hemisphere influenza season, I'd like to briefly summarize the avian influenza H5 situation, as there has been a lot of attention on H5N1. Globally, since 2003, 1,074 human cases of influenza A have been reported to WHO from around the world. These include H5, H5N1, H5N6, and H5N8. More recently, since the 1st of January 2024, 88 human infections with H5N1 viruses have been reported. Of these 88, 5 were reported this year in 2025. In animals, H5 viruses continue to be detected in both domestic and wild birds with spillover to mammals in many countries, and sustained circulation in dairy cattle in the United States. When we speak of avian influenza H5, it's important to know that there are many subtypes of avian influenza viruses infecting humans. There are also swine influenza viruses, which pose a threat to human health. WHO works with partners around the world on all of these zoonotic viruses, as well as with seasonal influenza viruses that are currently circulating. With all of this information from around the world, WHO conducts regular risk assessments. At present, based on the information that we have, WHO assesses the risk of zoonotic influenzas, including H5N1, to the general public as low. However, we assess the risk for occupationally exposed individuals as low to moderate, depending on the risk mitigation measures in place. WHO urges all countries to heighten vigilance, strengthen surveillance in people via WHO Global Influenza Surveillance and Response System, to investigate thoroughly all human zoonotic influenza cases, and to advance preparedness and readiness for pandemic influenza. We are working with our partner agencies, the World Organization for Animal Health and the Food and Agriculture Organization, to strengthen surveillance in animals, improve measures to reduce animal-to-animal transmission, animal-to-human transmission, and transmission to new animal species. Now onto the vaccine composition meeting that took place this week at the WHO Collaborating Centre for Influenza in the Francis Crick Institute here in London. Influenza viruses are constantly evolving, and that means that vaccines to counter them also need to evolve. WHO works with member states and technical teams, technical partners to update influenza vaccine composition twice a year, every year, to make sure that we have the best possible vaccines to protect people around the world. We meet once to prepare for the flu vaccine in the Northern Hemisphere and once for the Southern Hemisphere. During these meetings, global experts from WHO collaborating centers, national influenza centers, regulatory laboratories, laboratories from the animal sector, and other institutions review the circulating influenza viruses, assess the changes compared to last influenza season, and advise WHO about the updates needed for vaccine composition. This week, we met for the Northern Hemisphere. I would like to acknowledge the incredible work of the Global Influenza Surveillance and Response System, which is a global network of 160 laboratories in 133 countries, areas, and territories. This includes 152 national influenza centers. Jointly with our collaborators, GISRIS works year-round to monitor the influenza situation and the related viruses that are circulating. Based on this global collaboration of scientists and institutions around the world, we are able to assess the risk of emergence of novel influenza viruses and prevent epidemics or pandemics by implementing early detection and response measures to prevent zoonotic viruses that spill over into human populations from becoming fit for human-to-human transmission that can cause outbreaks, epidemics, and pandemics. This morning, we had an information session with the global vaccine manufacturers and regulatory agencies to announce the WHO recommendations so that they can immediately start the production cycle of seasonal influenza vaccines for the next Northern Hemisphere season. The full recommendations from the WHO vaccine composition meeting have been published today on the WHO website. These include recommendations for the composition of influenza virus vaccines for use in the 25-26 Northern Hemisphere season, as well as recommendations for new candidate vaccine viruses for zoonotic influenzas, including for H5N1 for pandemic preparedness. I'd like to thank all of our colleagues through GISRIS and also from FAO, WOHA, and OFFLU for their critical contributions to update zoonotic influenza candidate vaccine viruses. WHO, jointly with its partners, will continue with all countries on surveillance, preparedness, and response to seasonal influenza, avian, and other zoonotic influenza viruses with pandemic potential. Thank you. Back to you, Christian.
Thank you very much, Dr. Van Kerkhoff. Now we get over to the questions again. Please raise your hand with the raise your hand icon if you want to get into the queue. And you will need to unmute yourself when we give you the signal. And that first signal goes to Helen Branswell from STAT. Helen, hello, and please unmute.
Thank you for taking my question, Christian. Two questions, if I could, please. I think that the seasonal vaccine, that the only component that has changed is H3. Can you talk about what you're seeing there? And Dr. Van Kerkhoff just mentioned that there were recommendations for new zoonotic candidate vaccine viruses. The press release didn't say anything about that. Can you tell us a bit about what is being recommended there? Thank you.
And over to you in London.
Thanks. We're going to start with Ian.
Thanks for the question, Helen. We've had a very careful look at the global situation with all three circulating influenza viruses in the human population. The H3 component always gives us the most grief. It's constantly changing and evolving quicker than the other viruses. So it was an appropriate decision to update the H3 to the same virus that we recommended for the Southern Hemisphere. And we do that on the balance of what we expect that these vaccines will cover in the current and emerging viruses in 2025, 2026. So it's always a balance of what we know and what we don't know, and we have to make a bit of a judgment call at what's going to circulate in 9 to 12 months' time. So we do our best, and that's our selection for this particular vaccine update. And the other components, the H1 and the B components, have been quite stable in terms of the vaccine coverage with the existing vaccines. So there was no need to update those at this point in time, according to our assessments.
And so from the zoonotic front, there were two new recommendations for CVVs, as Maria mentioned. We follow what's going on at the human-animal interface, and we have this suite of candidate vaccine viruses representing what we think are some of the major lineages. The two new ones were recommended this time belong to the 2321A clade and the 2344H. So just to reiterate, in response to the 2344B, which is where most of the activity is, and we are pretty well covered with existing reagents. The 2321A was in response to activity in India. There was a human case detected last year in Australia from a child returning from India. Additional information came in from animal colleagues this year suggesting that virus is continuing to circulate in the region and it doesn't react well with existing candidate vaccine viruses. So again, as business as usual, we've filled that hole by suggesting a new CVV for that. The other one is the 2344H version. This is a virus that was once dominant in Southeast Asia. It seemed to be on its way out, but has re-emerged in a couple of provinces in southeastern China. Over the past year, 18 months, there have been human infections associated with that and continued circulation in poultry in that region. And again, not well covered by existing reagents. So we've filled that hole as well.
Thank you very much. With this, we come to the next question. That's Ashley Furlong from Politico. Ashley, please unmute.
Hi, it's actually Bloomberg now. Thanks, Christian. I just wanted to know if you could comment on the potential impact to vaccine manufacturing timelines in the US with regards to it cancelling the vaccine advisors meeting that would have obviously decided on the recommendations that have just been put forward today. And then I had a second question on the egg shortage in the US and as well as whether that would complicate production for this year's shots. Thanks so much.
That was Ashley Furlong from Bloomberg, and back over to London.
So I will start. So as usual, that WHO makes twice a year the vaccine composition recommendation. And it is always upon the countries, the regions, regulatory agency to decide the exact composition and the formulation of the vaccines that will be used in its own country or in its own region. And in different countries and regions, they use different format or forum to make such a decision. And for US, in the past, it's VRBPAC. So this year, we just heard from the media that the meeting will be postponed or cancelled. But it is really purely the national operation to decide to make the decision as to the composition and formulation of the vaccines that will be used in the Northern Hemisphere next season.
And maybe just to comment on the egg question. Again, the shortage shouldn't impact vaccination. These supply chains for the commercial stock versus the vaccine stock are different. So yeah, there's no problems anticipated.
Thank you very much, both. Maria, you want to go for the second part of the question from Ashley?
Can you repeat it for us, Christian?
It was whether the situation from the US with the CDC part made it more problematic this year. If I summarized it well, please, Ashley, jump in case.
Yeah, I can start, and I think Wenjing will want to come in on this. I mean, I think what is really incredible, and I have to say, I'm really happy to be here in London with these incredible group of people. The amount of data that is analyzed by this system, the Global Influenza Surveillance and Response System, with the WHO CCs, with the National Influenza Centers, with the regulatory labs, with the animal, what I said in my opening remarks is truly incredible. And that data that is shared, that data that is analyzed and characterized and scrutinized is shared year round. And so certainly, in the recent couple of weeks, there have been some changes in terms of contributions from our colleagues in the US. But this meeting took place. We had participation and an active participation from everybody in the meeting. And that was really, really great to see. The recommendations that are coming out are strong. They're based on the information that is provided within the system itself. I will use this as an opportunity to thank all of the countries that are participating in GISRIS, countries and laboratories, public health professionals, scientists who are testing patients, sharing samples within the GISRIS system, doing sequencing, uploading those to publicly available databases. All of that information is really, really critical from all of our member states, from all of countries around the world, whether you're a member state or not. And I think that that continued process, and now it's 73 years, right, Wenjing, in terms of how long GISRIS has been in operation, that will continue. So the system is strong. We do, as I've said in my previous remarks at the last press conference, we hope that the pause in the work that we're doing with the US is temporary, and we hope that we will be able to resume that in full force in the coming weeks.
Yeah, just to add to what Maria just said, is that the CDC participated actively in the WHO's consultation from Monday to Thursday, participating and also contributing with the data that they generated. This is just additional information.
There, that I think we can go to the next question, and the next goes to Olivier Desibourg from RTS. Olivier, please unmute.
Yes, thank you, Christian. Actually, my question was just answered in the last words. So my question was about the participation of CDC in the last meeting, in the data sharing. Actually, a precision question. Since when did the CDC did not share the data recently? And mainly, what do you foresee for the near future in terms of participation, collaboration, and data sharing with the CDC? Thank you very much.
Thank you. I think we'll start with Maria van Kerkhove again in London.
We're going to start with Wenjing, and then I'll come in. Yeah, Wenjing.
Yeah, I will start. So there was a period of time that CDC there was a period of time that there was no data coming out from CDC. However, if I remember correctly, is that on 14th February, because this date is very special, that CDC released a lot of data in the publicly accessible data platform, like he said, the sequence data. Actually, CDC also shared the data in time as other as other institutions in the WHO consultation. Data packages made them available for the consultation. Yeah, so this is type of the facts to this answer to your question.
Thanks. And on the second part of the question around what do we anticipate? I mean, I think within the global influenza surveillance and response system, this is a network. And the strength of the network is that it is composed of hundreds of institutions. We have several WHO collaborating centers. We have more than 130 national influenza centers, and the data comes in from a variety of different sources. It's not reliant on any one country. It's not reliant on any one laboratory, and that is a real strength of the system. And it's built that way. Because this is a system that's monitoring these viruses globally, it's important that the sources of information come from a variety of locations around the world, and they continue to do so. We will deal with every day as it comes, but we will continue to strengthen systems, continue to support governments on improving surveillance activities, providing clinical care for patients, but also to remind you that it's not only human data that we're looking at. So there's data that comes in from the animal sector as well, that is analyzed as part of the meeting that took place this week, but also with WHO and our partner agencies at WOHA and FAO, we're looking at a variety of different sources of information to make these regular risk assessments and to advise on what needs to happen in terms of pandemic preparedness, readiness, and response.
Thank you very much, Dr. Zhang and Dr. van Kerkhove. Next question goes to Alexander Tin from CBS. Alexander, please go ahead.
Hi, thanks for taking my question. Can you hear me?
Yes, indeed.
Okay. Sorry for some more US-centric questions. On the ERL side, can you explain whether the US FDA's participation and contributions were different from the past? And I also wanted to ask about two things we observed in the United States, that the H3 component was a worse match than last season, and that the flu season overall was more severe. Were either of those things prevalent across the Northern Hemisphere? Thanks.
Thank you very much. Back to London.
So with regards to EIL, you're right that we have an EIL lab in the CBER FDA. So CBER FDA is the same as CDC participated in the vaccine composition consultation just finished. They contributed again with the data package. So they participated as in the past. And with the second part about H3EN.
Yeah, so as I mentioned earlier, H3 is always the bane of our existence. We are trying to keep up with that virus. In fact, the vaccine effectiveness studies that we have, both the interim ones from the Northern Hemisphere and the final vaccine effectiveness statistics from the Southern Hemisphere, show that even though the virus has moved on a little bit, that the H3 vaccine was still relatively effective both in the Southern Hemisphere past influenza season and in the Northern Hemisphere current season. As you know, that in the United States, it's not just H3N2 which are circulating. There's also a high level of H1N1 circulating in the country as well. And so I think the match is not perfect, but it is a reasonable match and is still the best preventative we have against infection with influenza.
Thank you. I see Olivier from RTS has a follow-up. Olivier, you want to go ahead?
Yes, can you hear me?
Yep.
Okay. Yeah, it's a follow-up to my question before. I understand that this network, I was just wondering how important or maybe say how detrimental to the effort it would be to have this blind spot over the US not contributing to the efforts of data sharing, etc. So how detrimental to the entire effort would it be?
Thank you. And back to London.
So I'll start. Maria, in her opening speech, actually explained very well that this is a global network. This network works in a way collectively. I mean, in each part of the world, people conducting surveillance in different laboratories, they do their work complementary to each other. So that means that the GISRS is a global. It's truly global. And we even look at a goal, like by 2030, the coverage of GISRS could be 100. So that the GISRS could be a true asset of the world on the monitoring of respiratory threat in the world. So it would require the participation of all countries, indeed. With regards to detrimental, at least so far in the vaccine composition, like a decision-making, there's data available, data make available from WHO, from all the WHO CCs, and also from CDC and from CBER in the US. So maybe I'll just pause here.
Can I just add to that? And Richard might want to come in as well. We need to clarify that the US is contributing information to the global influenza surveillance and response system. There was a temporary pause in information that was coming from US CDC. There was information that was provided to us and to the system, certainly through for this meeting in particular, but sequences continue to be shared from the US. There's information that's coming out from USDA on the animal side. So I want to be very clear that the US is still contributing. I know that there's a lot of attention on the US right now, but we are going to continue to emphasize the importance of this global system that's in place. I've received a lot of questions about, one, did this meeting or could this meeting even take place if the US wasn't able to participate? And I think what we really need to make sure is clear is that absolutely, and of course, the US did participate in this meeting and we're grateful for that, but there's a huge system that's in place. And I think we need to make sure that all governments continue to prioritize the work around respiratory threats like influenza because of the threat that influenza poses. We know that the work that we do in influenza, there will be another pandemic. We don't know. It's not a matter of if, it's a matter of when. And so the system and strengthening that system is really clear. But just to come back to you, Olivier, on your follow-up, the US is contributing information. I don't know if you want to add.
No, nothing to add here at all.
Thank you very much. And we have another follow-up, and that was Alexander Tin from CBS. Alex.
Hi, thank you for permitting the follow-up. I just wanted to follow up on that third question I had. The US saw an unusually severe flu season this year overall. Was that common elsewhere in the Northern Hemisphere? I'm just hoping you can help us understand that context. Thanks.
And again, back over to London.
Yeah, so to answer your question, there was variation in the viruses which circulated globally. For example, in the most of Europe, it was a predominance of the H1N1 virus. So they had only had a low circulation of H3. China was almost entirely H1N1, and South America had a mixture of H1 and B viruses. So the mixture was a little different in the US. It was, in fact, quite similar to what we saw in Australia in the last season, where we had a mixture of H1 and H3 co-circulating throughout the season. So a very similar season to what we saw in the Southern Hemisphere.
Anyone else from London? No. Then thank you for the following up. Now we have Belisa Godinho still in the loop. Yeah, please go ahead, Belisa.
Hi, I'm Belisa Godinho, journalist writer from W Magazine Media with global broadcast based in the Portuguese capital, Lisbon. Influenza vaccine for the Northern Hemisphere. Will other influenza vaccines be administered to Southern, Eastern, and Western hemispheres with different compositions? And am I right? I am right. I ask you if it is possible to clarify if how related with climate and virus mutation, and if a person take the influenza vaccine in northern and travels to another hemisphere is equally immunized. Can you elaborate a little bit more? Thank you.
Thank you very much, Belisa. Yeah, I want a few clarifications on how the vaccine composition works. Over to London.
Yeah, the climate change one is a hard one to answer. The short-term effects and the longer-term effects on how that will influence influenza transmission and its different patterns. I think that's something we don't fully understand yet, and some groups are definitely working in that area. In terms of being vaccinated, when you're traveling from one hemisphere to another, if there are changes in one of the vaccines, then it would be a good idea to think about having another vaccine. And if you haven't been vaccinated for 6 months and you're traveling to another region that's going into their winter season or their influenza season, then that would be recommended. But these are discussions you should have with your medical person and consult with them about any of these sort of recommendations.
Thank you. And maybe a bit more on how the vaccine composition for the Northern and Southern Hemisphere work and why that's different. Maybe a few clarifying words for Belisa.
Well, the process is exactly the same that we go through, and clearly there is more data available for the Northern Hemisphere. We have a much larger proportion of national influenza centres in the Northern Hemisphere and a higher population, so there's more data than the Southern Hemisphere decision. But they're essentially the same processes where we look at all of the characteristics of the virus and try and predict what might be happening 6 to 9 months later when the vaccines are needed for the influenza season. So a very similar process. It's just a numbers game where there is more data available for the Northern Hemisphere.
Just to add also to Ian, it's not only the virus characterization data, but also like epidemiological data, the VE data, vaccine effectiveness data. Like for this vaccine composition consultation, we took into consideration of the interim estimate of the VE from the Northern Hemisphere, as the Northern Hemisphere is not yet ended yet. So these are all the data package coming together to make a decision what viruses would be the optimal choice to go to the vaccines for use in the upcoming season.
Thank you very much, London. And also, Belisa, I think you mentioned Western and Eastern Hemisphere, if I heard you right. So that has nothing to do with West and East. This is a part of the Northern Hemisphere and Southern here is for the winter season and the flu season we have in the North and the South. That's the reason why it's different for the Northern and the Southern Hemisphere. Next question goes to Tammy Hultman from All Africa. Tammy, please go ahead and unmute.
Hi, in view of the fact that this is a global season, this is Tammy Holman from All Africa. Would someone please comment on the role of African scientists and scientific centers in the development of vaccine composition?
Thank you very much, Tammy, and that's a perfect question for Wenjing and colleagues in London.
Yeah, I'll start, but I believe our collaborating center directors, they will have a lot to add. It started with a global system. So it is truly global. At the moment, the global system comprises 160 institutions in 133 countries, areas, and territories. And that includes, although I don't have the exact number, a lot of countries in Africa. So the national influenza centers there, they contributed, as all other national influenza centers in other regions, they contributed with the epidemiological data, they contributed with the representative viruses, they also report if there's anything unusual, they will send an alert to WHO CCs so that this could be looked at more intensively. So the global system, irrelevant to Africa, Europe, America, or Asia, it is equal because for influenza viruses, it's not really different. It can emerge anywhere. And this actually is the reason why the global system, we do need a global system to monitor the influenza, to develop the optimal measures, because this is the most cost-effective way in getting that down. So our collaborating centers to that.
Oh, just briefly to add that there are dozens of African countries that now contribute to the WHO GISRA system. And so they do make a valuable contribution, and they share information, they share sequences, and they share samples to London, to Melbourne, to Atlanta. So I think it's a very effective system, and South Africa, I just call them out, and they do an excellent job in doing epidemiological studies as well as their role in virus sharing, etc.
Yeah, and maybe down the other end. Here we go. So yeah, but maybe just to add to that, Tammy. So what you've just heard about from Wenjing and Ian sort of relates to the seasonal influenza situation, where truly the virus does move around globally, and the zoonotic space where we work a lot, it can be a bit different. So where there can be regional pockets of viruses of concern, and therefore in that case, specific information from countries across the globe is important. From the consultation we've just had, there was information from viruses in animal populations from Africa, for example, from Egypt. Our colleagues from OFLU, who are the expert group of WOA and FAO, also provided information from Western Africa and other parts as well. So, as always, we certainly appreciate more information and more data, but they certainly were represented.
Can I also just use this as an opportunity to plea to our government counterparts to continue to support surveillance in this area? There has been a lot of strengthened capacity globally, particularly in Africa, in our African region, around detection capacity, around sequencing, but that needs to be sustained. So this is something, we're working with all of our member states to do, and it's very difficult because there's so many challenges that governments are facing in terms of where they put their resources. And we know that the fiscal space for pandemic preparedness and monitoring pathogens like this is under threat. So this is really appreciated and it's used. And just to say, if you're seeing us in the room and the lights change, the lights go off if we don't move. So that's what's happening in the background here. Back to you, Christian.
Thank you very much. We have a follow-up from Helen Branswell. It seems we're closing the circle here. So Helen, please go ahead.
Hi, Christian. You may not want to take this question. I understand if you don't, because it's not flu related, but the fact that Mike Ryan was in the room with you, he may not still be, but if he is, I was wondering if it would be possible to ask a question about DRC, Eastern DRC, Equator, what is being seen there. But again, if it's not the right time, don't worry about it.
Let me look. I think we want to take it. And then let me do something else while he's getting ready, and before we want to hand it to him anyway. We come to the end of the other questions. So let me, because we had one question about the panelists again. So let me read out the panelists one more time because some of you didn't catch the full name. So I'll start from the list from top. So we have Dr. Richard Webby. He's director of the St. Jude Children's Research Hospital. He was sitting from the screen side on the right side, looking at the panelists. Then we have Professor Ian Barr, Deputy Director for the Victorian Infectious Diseases Reference Laboratory. We had Dr. Zhang Wenjing Zhang, the head of the Global Influenza Program at WHO. And we had Dr. Maria van Kerkhoff, Director at Interim of the Department of Epidemic and Pandemic Threat Management here at WHO. And we'll then come to Dr. Mike Ryan, Executive Director of the WHO Health Emergency Program in a moment. Now, we will send the notes from this meeting, or I think the transcript we could send afterwards. We will also share the names one more time with the sendout. You should have by now received the notes with the press release with the composition, and you should also receive the opening remarks from Maria van Kerkhoff. Now, let me see if we're ready. And Helen, please, can you just re-ask your question one more time?
Sure, thanks. I'm just wondering if you are in a position to give any more clarity to what's happening or what WHO thinks is happening in Eastern DRC and Ecuador province, where there's been sort of a high attack rate, it appears, and a substantial number of deaths. I've read that Ebola and Marburg have been ruled out, and that there have been a lot of people who've tested positive for malaria, but it seems like it's a more complicated situation than that. And I'm just wondering what WHO's current thinking on it is, please.
Thanks very much, Helen.
Yeah, you're referring to the cluster of disease in Ecuador, as in an unknown diagnosis, correct? Not to the Kivu situation.
Helen, can you unmute?
Yes, that's what I'm talking about. Thank you.
Okay. Yeah, no, that is something that we've had under intense investigation, and when you look at the it's not the same issue that occurred previously in southern DR Congo, but there certainly has been a significant event early on in this situation, in which we had a large clustering of deaths that were mainly focused in young men in a particular village. Then there appears to have been an extension of that. But what's clear from the epidemiology is, as the investigation team broadened their case definition, a lot of other issues, like normal background diseases, malaria and others, have become mixed up with that. Our current assessment of the situation is that what we have is a fairly limited in time and very limited in geography cluster of unusual deaths. It has been proven negative for hemorrhagic fevers. Other samples have been taken. A systematic investigation looking at all the suspect, even the extremely suspect cases, has been done. And there clearly is, based on onset of symptomatology to death, it looks and appears very much more like a toxic type event, either from a biologic perspective, like a meningitis, or from a chemical exposure. And there is some indication now from the authorities that there's a very strong level of suspicion of a poisoning event related to the poisoning of a water source in relation to that specific village. So that's under investigation by the appropriate authorities in country. We will continue to investigate. Clearly, and it's something that our press officer here at ECA has mentioned to me many times, that we are very concerned about these events until we prove that there's a mixed epidemiology and that many people are dying of malaria and other diseases. And once we establish that it's not some major new earth-killing virus, we all lose interest. This is a significant set of deaths and disease caused by multiple agents in a vulnerable population. Clearly, at the center of this, it would appear that we have some kind of poisoning event. We will not stop investigating until we're assured that the risk of that, or that the true cause and the absolute cause of what's occurring here is fully investigated, and we will stay vigilant. Again, credit to the authorities in DR Congo. I think one has to really commend our colleagues who work in DR Congo. I mean, they're dealing with the situation in North and South Kivu. They're dealing with an explosive mpox situation. They're dealing with cholera. They're dealing with meningitis. They're dealing with malaria. They're dealing with so many other crises about internal displacement of population. And yet the provincial response team were able to get to the field. They were able to take samples, not without difficulty logistically, not in any degree of 100% perfection. A national response team was deployed to support that team, with support from WHO embedded staff, and further samples and further investigation has helped elucidate the cause further. So what I see here is again, our ability collectively to be able to detect and investigate unusual events quickly is very important. And again, this event was reported into the system and reported internationally. And again, the transparency of the government of DR Congo, for me, is very, very impressive. And it's part of the business we do every day. In the last 24 hours, we've looked at 1,397 signals, potential signals around the world of epidemics. We're currently tracking over 350 different events around the world, of which 39 are considered to be graded emergencies by WHO. This is based on multiple surveillance systems that we manage around the world, not least of which is GISRES here, but we've got the Gremlin system for measles. We've got the GLADNet system for high-threat pathogens. We have DengueNet for dengue. We have the kind of generic surveillance with the event-based surveillance systems that we use through the epidemic intelligence from open source system that we use here in Geneva and many other partners use around the world. What we have is a very, very comprehensive network of networks that are constantly looking at what's out there in the natural world amongst our populations, seeking to pick out, to track, to monitor, to characterize disease, to mount response, to develop vaccines and other countermeasures on the basis of moving samples around the system, to trigger responses, to trigger surge capacity. This system has evolved globally over the last 70 years. The United States, amongst others, have been a huge part of developing the capabilities of our collective effort to protect our populations. Any gap in that is a gap. Any hole in the net is a hole in the net. It doesn't matter where it is. If there's a hole in the net because there's no capability, or there's too much poverty and there's not enough investment in technology and the systems, that's a hole in our net. Doesn't matter what caused it. If there's a hole in our net because there's a lack of transparency or a lack of commitment to the process, that's a hole in our net. So we do have to work to continue to develop, to continue to sustain all of these global systems, be they specialized systems that deal with specific diseases like flu, or be they generic systems that deal with this unknown disease in DR Congo. We need to have this mixture of different systems that allow us to have the kind of safety net after a safety net, that allow us to pick up a signal in one system that we might miss in another. Many of those systems are under huge pressure. The measles and rubella global system is under massive pressure right now because it's lost all its funding. So we do have concerns and we do have worries. But I can assure you, Helen, that in the area of picking up signals from around the world, we still remain very strong. But as I said, any hole in our net is a hole for everybody.
Thank you very much. And with this and these remarks, and also the follow-up question by Helen, we've come to the end. And again, want to thank the panelists in London at the WHO Collaborating Center at the Crick Institute, Dr. Richard Webby, Professor Ian Barr, Dr. Wenjin Zhang, Dr. Maria Van Kerkhove, and here in the room, Dr. Mike Ryan. Thank you all very much for a very interesting briefing, and I wish you all a good day.